name is Dr. Christina Goldstein. I'm an orthopedic spine surgeon at the University of Missouri in Columbia, Missouri. And today we're going to be talking about medical management of traumatic spinal cord injuries. I have with me two of my colleagues.
I'm Scott Daffner from West Virginia University. I'm an orthopedic spine surgeon.
I'm Greg Schroeder from Philadelphia with the Rothman Institute at Thomas Jefferson University.
So the reason that we're talking to you today is because as surgeons, we tend to realize that acute traumatic spinal cord injuries can be managed surgically and should be done so in a timely manner in order to decompress and stabilize the injured spinal cord. But what we're maybe not so familiar with is the adjunctive medical management of spinal cord injury, which is really important because the secondary injury cascade that comes along with spinal cord injury leads to ongoing issues with the spinal cord in terms of things like hematoma formation, edema, ongoing cellular death, and apoptosis. And all of these things lead to changes within the structure of the spinal cord, including cystic cavitation, scar formation, and all of these things can prevent regeneration of the spinal cord as well as the ability of patients to heal and have good functional outcomes after their injury.
Completely agree with you, Christine. I think that, we always know the Staskis trial that basically says operate on a patient as soon as possible. The importance of, really time is spine. What we have to think about is when you're taking care of these spine trauma patients, so they come in at 2 a.m, you take them urgently to the emergency or to the operating room. But once you're done, how do you handle it? And I think there's a lot of different things that are kind of going into it. One of the kind of classic things that people talk about is kind of the mean arterial pressure. Should we keep it elevated? How long should we keep it elevated? How do we do that? The evidence behind that is pretty limited. And so if you look at a lot of the systematic reviews that come out, some of them say you should do it, some of them say you shouldn't do it. But I think really since about 2015, there have been a couple of good studies that have really looked at it and shown that, when you keep the mean arterial pressure elevated, often the goal of keeping the mean arterial pressure elevated is to increase the spinal cord perfusion pressure. And so what you're trying to do is get blood flow to the spine to allow it to heal. And there have been multiple studies that have really suggested that keeping the blood pressure elevated does at least in a decent number of patients increase their ability to have really conversion of one or more ASIA levels. There's a little bit of debate as to how long it should be for, when it should be, or how it should be done. I think in general, there's no real consensus about 5 versus 7 days or 85 versus 90. But I think the goal of keeping the MAPS elevated after a spinal cord injury, I do think is important. I also think there have been some studies kind of suggesting, which pressor would be better. I don't think there's a definitive answer on that. Dopamine has been shown to possibly decrease actually the spinal cord perfusion pressure. Even though it increases the MAPS, it may increase the intrathecal pressure. So there's some discussion about using norepinephrine, but these are kind of really early studies that we don't really have a great answer for on that. But I think that's kind of one of the things that as a spine surgeon, when you're done operating, you can think, let me talk to the ICU because this patient should go to the ICU. What else can we do to decrease the secondary hit?
And I think in general, many of those studies show that there is good consensus that elevating the mean arterial pressure post-op is safe.
Right. You may have some complications, but it's hard to separate out whether those complications are really, complications from a spinal cord injury versus complications from keeping your blood pressure elevated. It's important when you talk to the families that you let people know what a serious injury this is, that there are, very high risks of complications. The risks of DVTs have been quoted somewhere between 25 and 50% in these patients. So patients have to understand that this is a injury that affects the entire body, the entire nervous system really below that level. And so there are going to be secondary complications after the injury.
And how about you, Scott? What else do you do for your patients?
Well, so obviously, the surgery takes care of sort of the direct injury that we can see. There's a number of other secondary measures that we address. In addition to the blood pressure management, we talk about various other neuroprotective strategies. Probably the most widely talked about is the use of steroids. That is still controversial. It sort of waxes and wanes whether they're recommended, whether it's recommended against it. Without going into a lot of detail, the current recommendation, I think, is that it's an option. And I know at our institution, our policy with steroids is we make it available as an option depending on whether or not the patient has concurrent chest trauma or other contraindications for it. So we'll kind of leave steroids alone at that. There's a number of other medications that are being looked at currently. There's two phase 3 clinical trials being run for two other medications. The first of which is riluzole, which is FDA approved for use in treatment of ALS. Mm-hmm. And that's one that works basically by mitigating the excitotoxicity. When there's a spinal cord injury, there's a change in sodium and calcium influx into the presynaptic neuron. It releases glutamate that causes overexcitation, and uncontrolled excitation of the postsynaptic neuron ultimately leads to cell death. And the way riluzole works is by managing those voltage-gated channels and reducing the excitotoxicity of the postsynaptic neurons. Again, they completed a phase 1 clinical trial. It seems reasonably safe. There's good preclinical data for it. It's moved into a phase 3 clinical trial. Mm-hmm. And again, because it's already an FDA-approved medication, it's a very tempting drug to kind of translate into use in spinal cord injury. The other medication is Sethrin, or what's called VX-210 now, which functions a little bit differently. And that's a medication that is applied directly on the spinal cord at the time of surgery, diffuses through the spinal cord, and has both neuroprotective and neuroregenerative components to it that, again, mitigates some of the changes from inflammation and also helps prevent the loss of axonal regrowth that can happen as a result of some of the other mediators and proteins that are released during a spinal cord injury. So those are two sort of promising medications that are on the horizon, not available yet, but certainly something to look forward to, keeping in mind the challenge is always with translating things from the benchtop to the bedside.
Right. And then certainly in terms of ongoing neurologic repair and recovery in the intermediate and chronic phase, so after the 2-week and then into the 6-month and longer phase, there are a lot of studies that are currently in use, several animal models of spinal cord injury, and then human studies going on in terms of looking at things like stem cell treatment, different inhibitors of the impairments to neural regeneration that could be used to try and break down extracellular matrix products which prevent neural repair, as well as lots of other different types of methods, even different biomaterials that are being produced to try and allow for spinal cord healing. But very, very early phase studies and nothing at this point that we have to put into clinical practice.
I do think those are exciting. There's been, though, a lot of discussion, 10 years ago kind of about the ethics of embryonic stem cell and things along that line, and should we be moving in that direction. But really today, I think the induced pluripotent stem cells are really hopefully a way that we can take our own cells in chronic spinal cord injury patients and really revert these cells back into neuroprogenitor cells. And so you can actually get away from really the question of, do we need to use embryonic stem cells? Do we, how do the ethics play into this? Instead, we can actually convert your own cell back into a neuroprogenitor cell, which 20 years ago we thought was crazy.
Mm-hmm.
So while it is early phase now, I think it's something that is exciting, and maybe nothing will come of it. But it's a way that we can now do something that 20 years ago we just didn't think was possible.
So for some additional reading and information around this topic, in 2017 there were some new guidelines published from AO Spine regarding the management of traumatic spinal cord injury in terms of medical management. And there are also some excellent review articles, including one in 2017 from Nature Medicine Reviews regarding medical management and the pathophysiology of spinal cord injury. Certainly much more detail than we can cover today. So thank you very much for joining us.
Thanks for having us.
Thanks.